Hi, everyone. Good afternoon from Washington, D.C. I think this is our fifth webinar that we sponsored since COVID-19, the things around COVID-19 began. We're going to have a great, thoughtful discussion with you all on just federal policy updates. But before we do that, I'd like to want to go ahead and congratulate our very own Mia Keeys. She says other people worked with her on it, but she just published a book all herself and on health equity.
All myself.
Specifically, there's a chapter, The Critical Discussions of Race and Racism Toward Achieving Equity in Health Policy. So that was all her. So congratulations.
No, not all me. This is the book, and there's folk in it, but I will at least show my chapter because I'm very proud. So just in case you can see it, it's the longest chapter in the book.
Look at that.
Enjoy it.
And so with that, we have that type of quality person leading our discussion today. And I'll turn it over to her.
Brandon, thank you so much. And I appreciate the shout out, but also the accountability. You know, this is the work that we do, and we're supposed to be leveraging our gifts to spread the word about how equity really is the critical nature of delivery of healthcare and such like that. So I'm excited again to be joining the National Minority Equality Forum team to today discuss something that a number of us are probably really looking forward to, policy updates with respect to COVID-19. We have two really stellar panelists to help us talk through and walk through a lot of what's going on to help unpack a number of things. So audience members, get your questions queued up. And just as always, if you do have questions, please put them in the question and answer box, not in the chat box, because we won't field it from there, okay? But otherwise, if you have comments, put them in the chat. So I would like to introduce our panelists. We have with us Wintta Woldemariam, who serves as the policy director to U.S. House Majority Whip, James Clyburn. And prior to working on the Hill, Wintta's been all over the DC scene. She's also been all over the Texas scene in terms of working for members on the House and also in the state levels there. So we're really excited that she can bring with her time and give us her energy and help us to walk through a number of things. And then I should also say she used to work for the Obama administration, and I know that I'm really interested to see if there's any connection in terms of what you're seeing with COVID-19 compared to H1N1 under the Obama administration or Ebola and such like that. But we'll get into that later on down the line. We also have with us today Robert Jarrin, who is a strategic advisor to several different companies and medical associations, and he works on issues related to digital medicine across the life sciences. And he's also a professor and adjunct faculty member at my university, my current university, George Washington University, and in the medical school there, and also at Georgetown. So we're just going to go ahead and jump right into it. I'm going to throw the first question over to Wintta. And although this will be a conversation, so Robert, please feel free to add if you feel so inclined. Wintta, just tell us about where we are now. Where are we? Because the next part of that question is where are we going with respect to forthcoming COVID-19 stimulus package?
Well, thank you for having me today, first of all. And congratulations on your book. That's very exciting. Don't want to let COVID steal the joy that you have for that amazing accomplishment. I'd say where we are is right now we have a house that is on fire. We have a forest fire. I mean, we have a very big fire that's evolving, and we are using all of the tools that we have to try to put that fire out. And when you have a fire, say like the fire, what are the brush fires they have in California? There are a variety of consequences, some foreseeable, others not foreseeable, right? We know that there might be a loss of life. We know that there might be a loss of property. We know that there is environmental damage. And I think that's been the example that the analogy I've been using, because I just think it is analogous, because this is just something we don't have control over, and we're doing our best. We're using different resources that we think can help. But part of our challenge is, we have, so here's some water, Mia. I'm giving you some water to put the fire out. Well, maybe you and I have a disagreement about what to do with that water. Maybe I'm saying, hey, Mia, throw the water on the house. It's on fire. And maybe you're like, nope, let's throw the water on this other thing over here that is, that's tangential to the house being on fire. And so we're trying to just kind of apply as many resources as possible to mitigate the loss of life and mitigate the economic damage that's occurring. And I would say that if you kind of think about that analogy, that's what you can expect in the next package, is more resources, perhaps now that we've done this a few times and have now had an opportunity to see what the blind spots are. Maybe we will have things that are a little more narrowly tailored or technical fixes to some of the things that we've done before. But what I expect is the application of more resources in a tailored way to try to put the fire out.
Yeah, I really appreciate that analogy. It's quite vivid, and I think all of us can see exactly what it is that you're talking about. Robert, how do you want to add to that?
Yeah, I'd love to. And first and foremost, thanks for having me. I'm honored to be a part of this panel or webinar. Apologize for the facial hair. Some of the people that I saw in the list of invited guests or those that are going to be listening know me, so they know that they've never seen this. So I'm just going to go with that. But Wintta, I'm right there with you. And the way that I like to always look upon the small little patch of area that I work in. So I work in what we call digital medicine. And for those that are really unfamiliar with that, think back 8-9 years ago when the idea of having medical devices that are part of your everyday world could not communicate either with a cell phone, a smartphone, a tablet, a PC, a home health hub, whatever, and let's say that you had, you were one of one out of every 2 Americans who actually has a chronic illness, and you used home use medical devices like glucometers and blood pressure cuff monitors and weight scales, spirometers, pulse O2 or pulse oximeters. Those are everyday medical devices that are used to treat and manage a variety of different conditions. And up until, I'd say probably a decade ago, most of them did not communicate with any aspect of healthcare. Now we have the advent of mobile broadband networks. We've got, smartphones that have more computing power in your pocket than Apollo 11 did when it reached the moon. I can go on and on. So it's a very different healthcare world. But unfortunately, rules and regulations did not really, how should I say it, modernize along the continuum that technology and healthcare has modernized. So it's always been a problem to really be able to help with the adoption of those types of technologies. So fast forward, we have a pandemic, and suddenly, CMS goes from one day of, hey, if you're sick, go see your doctor, your clinician. But the idea is that you have to go into the medical center to actually get care. And literally within the course of a couple of days, they changed to stay away from any healthcare facility because we want to make sure that we, protect human life. We want to make sure that we don't get healthcare workers sick. We want to make sure that we don't get you sick if you're actually not sick with COVID. And we're going to figure it out and try to come up with, a way of paying for virtual care, which up until recently, we've actually shunned. So that's a huge, huge change, a mindset change, a culture change, and quite frankly, a business model change for everybody that's involved in the healthcare system. And we have to, remind folks of how big that is. The Center for Medicare and Medicaid Services operates on a budget of over $1 trillion US taxpayer dollars. That is a mind-numbing amount. And people typically don't realize that it's the second largest line item in the US budget, second only to Social Security. So that's an astronomical amount of money that they're in charge of. But the majority of that was never really utilized for things like telehealth. I think a report that I've cited in some documents that I've drafted, it's a report from CMS actually cites that in 2016, it's the last time they actually looked at how much money was spent on telehealth, or that they publicly have disclosed that. In 2016, it accounted for telehealth services, the expenses accounted for about $27 million, and that's 27 million with an M out of the Medicare, just, let's say Medicare budget out of CMS's budget was about $570 billion that year, billion with a B. So you can see that it accounted for less than, 0.25% of 1% of money, which means that telehealth was not being used for, care and virtual care. So it's been a big deal. We're drinking from a fire hose. On, January 31st, Azar declared a public health emergency. Trump didn't, follow up with the Stafford invokement up until March 13th. And those two things are vital because those are, in essence, what allows for a secretarial waiver, the authority bestowed on the secretary to be able to start waiving some of the program requirements to make it easier to pay for things like telehealth and remote physiologic monitoring and virtual care, which is really right now the focus of CMS, because they really do want to keep people away from the institutions. And kudos to Congress because they've moved so quickly on inserting other language in, CARES 3. I call it CARES 3, really there have been 4 different legislative vehicles, but each one has slightly modified and furthered, the secretarial waiver authorities. But I fear very much, given the state of politics, not to get into politics, but, sometimes things change on the drop of a hat. And both the public health emergency can be not extended or, revoked, or the invocation of the Stafford Act can be revoked. And there go all the waivers that really have allowed for telehealth to, flourish. And that's really kind of, a bit alarming. So I'll end it with that.
Well, I want to unpack what both of you have mentioned. So Wintta, you led us with the analogy that it's hot and we're all burning and we feel the fire, right? And you've talked to us about really putting the resources where the fire, is greatest, and trying to make sure that that's where we're putting our manpower, our woman power. Robert, you talked to us about how incrementally, more specific to how care is delivered, telehealth is being ramped up to meet the changing needs of our nation and potential patients. I want to go deeper into this because, as you know, and as the National Minority Equality Forum knows and lives on this platform, that there are communities, there are a number of communities that are feeling the fire more than others, right? And so I'm wondering if you can give us 2 things. One, talk to us about how the bills so far have been iteratively seeing to the needs of those communities that are marginalized and minoritized and have been disparately feeling the fire more than any of us. And of course, recognizing that we're all hot, right? But tell us how the resources in the bills are addressing the issues. What are the gaps? And Robert, if you can expound on, the fact that telehealth is fantastic, but not everyone has access to smart technologies and such like that, and talk to us about audio and asynchronous telehealth communications. And I'll end by saying this. I also want to know how, in the words of James Baldwin, these bills are going to help us to avoid the fire next time.
All right, Wintta, you're on mute.
Oh, I was like, those are fantastic questions. So those are very kind of good prompts, and I'll do my best to address them in no particular order. So as Mia mentioned, I am policy director to House Majority Whip James Clyburn, who is from South Carolina, represents parts of Charleston and Columbia in his district, but also most of his district is pretty rural. And I'm not sure if you all saw the press conference. So this week he's done 2 press conferences with the Speaker of the House. The one yesterday, I think is the most relevant to the last part of your question, was about the need for rural broadband. And we're saying rural broadband, but what we mean is broadband in areas that are kind of currently not connected. So just like medically underserved areas can be in rural communities as well as like in urban and suburban pockets. Same for broadband. And, you know, one of the pushbacks that I saw in the Twitter chatter was, well, what does broadband have to do with coronavirus? Well, it has a lot to do with coronavirus if you are in one of the communities where, you know, 25% of rural hospitals have closed over the last 10 years. Or if you are, or if you were trying to not overwhelm our healthcare infrastructure by going to a hospital to seek care that is important, but not, but can be done remotely, you know, that can be done via telehealth. And so talking about the importance of, I mean, I know that this is a healthcare forum, but when we're talking about just all of the things that we're kind of talking about related to coronavirus, are our children going to be enrolled, able to receive their education? I live in Southeast DC, and I was talking to a colleague who said that some of the schools in this community, actually, they're not going to go through the end of the actual DC school year here because 25% of the children in the schools here have not been heard from since they got out of school. And so, you know, how do we make sure that those children are able to receive their education? On the healthcare side, how do we make sure that people are able to access medical attention from their homes? So that's kind of on the broadband piece. I know that that's Robert's question, but you know, it's critically important, and it's certainly at the front of mind for House Democrats with respect to how do we make sure that we don't find ourselves in this situation again. So, and the first part of your question. So, you know, the speaker, Mr. Clyburn, did a press conference about the select committee that the speaker is standing up. And the purpose of the select committee is to ensure that all resources, taxpayer resources that have been deployed or are being deployed for the purpose of combating coronavirus and the coronavirus crisis, larger crisis, kind of healthcare and economic, is, you know, part of the job of that select committee is going to be to ensure that those resources were deployed in a way that is efficient, effective, but also equitable. And that there's some fairness, that there's a level of fairness to making sure that all people, especially all underserved people, medically underserved people, are receiving the resources, and that people are not getting a death sentence because of what communities they come from. And to speak to kind of the first part of your question, Mia, you know, when we passed the first couple of bills, we didn't have this data available that talked about the impact, the kind of racial disparity that you know, that data affirmed what many of us probably already believed was going to be the case, but we didn't have that data available. And so the Congressional Black Caucus and the other members of the Tri-Caucus, the Congressional Hispanic Caucus, and the Congressional the Asian and Pacific Islander American Caucus, rather, have been, plus the Native American Caucus, have been very vocal to ensure that whatever passes next is going to be inclusive of those perspectives and is going to be narrowly tailored in a way, you know, you have to send the most aid to the places that have the most need. And I think that that is going to, I was reading an article this morning about the PPP program and how I think someplace like one of the Dakotas, for example, they were saying has like 80% of their need being met, but you know, a place like California only has 38% of its need being met. And so just thinking about what level of fairness that there's going to be in making sure that, you know, like I said, we're not sentencing people to death. Or not sending PPE there, or whatever the case might be, because of, you know, where they're from, or, you know, whether their governor is a member of one political party over another.
Yeah, so Wintta, you a couple of things. One, we're neighbors. I live in Southeast as well. I live near Pennsylvania Branch Avenue, so hey neighbor. And I think you nailed it with your casual remark about, you know, urban, because I see the broadband issue as not just a rural broadband issue, which unfortunately to the FCC, it's always been, you know, couched in that idea that, hey, we've got problems with, you know, rural broadband and the proliferation of broadband access, even though the FCC also used to say very, you know, in a way championing itself, you know, hey, you know, 95% of the US population is covered by at least one, you know, mobile broadband network. But that's really misleading, because in, rural areas, that's not the case at all. And I would argue even in some urban areas, where I live, I've got no broadband connectivity in my house, mobile, and I've got a certain carrier that I'm not going to mention, and they don't cover this area, which is ridiculous to me. So in my house, I can't receive mobile calls, and that's crazy. It's interesting because right down the street from my home, there's a elementary school that was featured on an Ellen DeGeneres show where Michelle Obama came in. Ellen gave this huge amount of money to be able to buy tablets for the students. I knew that it was an area of need. I didn't realize how much. Apparently 60% of the kids are in a foster situation in that school, Randall Elementary. And that was shocking to me. And they gave most of the kids a tablet so that they could actually communicate for situations exactly what has played out, which is not really necessarily, on certain radars. And I say this because over the course of my time, so the last 20 years, I formerly worked for Qualcomm Incorporated. Qualcomm's the world's largest producer of wireless chips. So if you're using anything that's got 2G, 3G, 4G, 5G, you're using Qualcomm's chip or their technology. So I've been very involved in the communication space up until when I left about a year ago. And to me, I always looked upon the FCC as, guys, you can do so much more. Their rural healthcare program was tapped at $400 million. And it was specifically to buy radio access network because that's what the statute said, not allowing them to actually buy services or these types of devices for areas of need. That was always a problem. They then got another fund for $100 million last year. Like $100 million will buy you a couple of radio base stations, in the middle of nowhere. That's really not enough to do anything, not just in rural or suburban or urban. And, now they've received, I think through CARES, another $200 million to be able to buy some of the services and some of the devices that, people need to be able to communicate effectively now that we're trying to keep them away from facilities, for social continuity, for social distancing, and be able to actually have things like telehealth consults. Like telehealth is wonderful, but it's very statutorily restricted to, it has to be live voice and video. And everybody typically talks about digital medicine as if though it's quote unquote telehealth. It's not. If I'm actually doing something like I give someone a medical device and try to monitor them, it doesn't get paid. Up until recently, it started to get paid. And the American Medical Association actually had a big part to do with that. And, full disclosure, I'm an advisor to their Digital Medical Payment Advisory Group. So I was part and parcel of creating the new CPT codes that were then adopted by CMS. But, not being able to have that kind of touch, that kind of communication with a provider, especially with what's going on now, is tragic. It's a lost opportunity. So this is a huge area and an area that needs upheaval, and it's not the fault of FCC, but in the past, Congress has not devoted what they should to this area. And I'll just say that, I feel like the Democrats kind of get it, but we need it all. So.
We really do. We do need it all. And I just want to pick out a couple of things that you all said in terms of those who are really feeling the fire. Wintta, you mentioned persons living in rural areas. Robert, you also mentioned the same. But then also those who are living in urban areas without complete coverage, right? So geographically speaking, it matters, but it's not just persons who are living in rural areas, right? Wintta, you mentioned medically underserved areas. You mentioned children. And these are people who, irrespective of political leaning, everyone loves or knows a child. Everyone, to some extent, understands that there are, geographic differences in terms of access to broadband, access to care, and everyone has at some point either been a patient in a health system or will be a patient in a health system or love someone. So these are issues that, irrespective of race, ethnicity, your leaning in terms of wealth status and again, political party, this matters for all of us, right? So rising tides, what is it?
Lifts all boats.
Lifts all boats, right? So when you're talking about, to your point, Wintta, earlier about equitable distribution, this is something that all of us need to be aligned with, right? Really making sure that we're grounding all of our next works on the policy front in equity, in an equitable lens. So I want to go on to another question, and just picking up on two things that you both mentioned. So Wintta, you were talking about the coronavirus select committee that that what Clyburn has established. Can you tell us a bit more about why it's been established, the goals of the overall committee, and how can people on the call and the general public be helpful in terms of either getting the word out or being a part of that?
Well, so I think the committee was partially established because the president, when he signed the CARES Act, said he was going to do his own oversight, which as a former investigations, never former, as a always investigations attorney, I know you can't investigate yourself. So I think that's the genesis of this exercise, and it's supposed to be based on the Truman Committee, which, there was, I forget the exact number, but some kind of very large number of committees that were set up during World War II to, got my history, I'm like World War I, World War II, to investigate the billions of dollars that were being spent on wartime efforts, and to ensure that taxpayer resources were being spent in a way that was efficient, appropriate, and to, one of the earliest kind of discussions of the waste, fraud, and abuse rhetoric that we're all familiar with. So that is what the select committee is going to be, is modeled after. And I think ultimately the Truman Committee, which was made permanent in the Senate, it's now the Permanent Subcommittee on Investigations, they ended up saving the taxpayers something like $15 billion, which we know is a lot of money now, but certainly was a lot more money in those times. So that is the kind of spirit with which this committee was established. And really they're going to be looking at a number of issues. That the thing about this, I mean, this thing is so big, right? This whole coronavirus pandemic. So there's the pandemic, like the actual disease or virus rather, and people being impacted by that. But then there's also, well, how does this impact people's jobs, right? None of us has ever seen anything like this in the United States. Maybe we've seen versions of this depending on, where we all come from. We may have seen iterations of this where maybe we're shut down or there's disease, but this is kind of unforeseen to see the world shut down in this way, and certainly during most of our lifetimes. And so I think one of the tasks that the Select Committee has is kind of isolating each of these components and looking into testing, looking into deployment of PPE, looking into the PPP program, just kind of looking into all of the things related to the pandemic itself, and then surrounding the pandemic, the surrounding crisis that has resulted from the pandemic and from the kind of protocols that we've had to utilize during this, the shutting down and so forth. I think the way that, looking at racial disparities, looking at, we'll be able to have elections in November, right? We've seen in Ohio, for example, we saw an election, primary election get canceled 90 minutes before election day. So how do we manage that? First and foremost, the priority here is about mitigating the loss of life and making sure that we are prepared, to speak to your last question, to, in the future, if this comes in the fall, or when we have to deal with this again, or just kind of planning. There used to be a person who would have had this job, right, who used to work in the National Security Council at the White House. So just making sure that we're prepared for what comes in the future, and that we're able to kind of address each of these discrete issues. And the way that I would say that participants, you all couldn't be helpful, is making sure to, stay in communication about the data that you're seeing, stay in communication about what you're seeing on the ground. If you are an essential worker, or if you have visibility into essential workplaces, just kind of, or if you're a small business, whatever it is, just kind of stay in contact about what it is that you're seeing in your experience.
Thank you for that, Wintta. That was quite clear. I want to go back to you, Robert, and talk about, so you were talking about CMS and the budget lines and changes that have occurred over some time. I want you to expound on that a bit. So there have been a number of policies and regulatory developments at CMS, but also other agencies, including FDA, related to this public health crisis of COVID-19. Can you go into greater detail about those developments for us?
Sure. So as a result of the secretarial waiver authority and the work that Congress has done, HHS as a whole has been on a 24-hour crush trying to remove the typical program requirements that they see would be obstacles for trying to deliver care. Healthcare, and it comes in a variety of flavors. With FDA very specifically, it's been trying to create what they call emergency use authorizations and delivering guidance that during the public health emergency, companies are allowed to do certain things. For example, change their labeling on their medical devices, change the intended use slightly for a medical device that isn't necessarily something that's considered, X, Y, and Z, but now you can do it because of the public health emergency. The big area with that has been obviously for things like PPE, which is, personal protective equipment, as well as things like ventilators. The ventilator need was a big deal. There are a lot of companies out there, I represent one that works in, the sleep apnea and the respiratory care space. And although they do make ventilators, invasive and non-invasive ventilators, the way that FDA has been able to tweak the regulatory language allows them to be able to reach a broader group of patients, especially now in a time of need when we have a respiratory disease on that's really the core of what's going on. So all of that, from the one side, FDA being the agency that's responsible for overseeing medical device rules and regulations, and their very quick use of emergency authorizations is actually in many ways a good thing. In some ways, I don't always agree with what they do. For example, just last week, they came out with a guidance on what they consider digital therapeutics. That's a very sexy term these days for things that, for application software as a medical device, basically, that can help with cognitive behavioral therapies. And FDA came out with an unforeseen guidance that, in essence, relaxes all regulations and places a great majority of these types of devices under, something I call enforcement discretion, which means that the agency will not obligate requirements under the law. And these are, things that are used in the psychiatric field for people that have, diagnosed, behavioral issues. And I see why the agency is doing it, right? They're trying to actually speed these things to market and help people that are right now in social isolation that can really use these types of devices. But nonetheless, something like that, it caught my eye only because typically these are very highly regulated spaces and areas, and I'm not quite sure where I lie on that. I think, yeah, it's good, but at the same time, I just don't want bad actors to come out with things in the marketplace and sell them and say, oh yeah, I'm under enforcement discretion and no one can come after me currently during this public health emergency. There's this, give and take, which is a very hard thing to do in medicine. And it's interesting, right? Because I read this wonderful, I guess it was just a piece that Johns Hopkins had written that they put on their coronavirus website a few weeks back, where they were talking about some of the societal implications of being sheltered in place, being quarantined. You have, a greater amount of spousal abuse, child abuse, the use of drugs, et cetera, which happens in these situations. And we don't always have the social community networks, and most certainly not right now, that, address some of those things. And maybe some of those things can be addressed through, things like apps and, interaction with doctors and with, clinical psychologists and psychotherapists, et cetera. So it's a very, very big deal. And it goes back to what Wintta was saying, the enormity of what's happening on every level in every sector of society just can't be comprehended. We have 30 million people right now that are unemployed. We used to, look just about a month and a half ago at, a couple 100,000 and think that's, kind of a big deal. I mean, think about that. So anyway, I hope that answers your question. I'm not sure that if that's what you were looking for.
No, that is a clear answer. And I appreciate you making that connection between the significance of telehealth to also help to alleviate a lot of these socially determinant factors with respect to our health. So I'm at the AMA. Of course, we're a medical organization. We're a physicians advocacy organization. So most of our practice and and focus is in the clinical setting. But I'm also at the Center for Health Equity. And so what we know and what the overall organization is now also making known to the public is that most of our health, up to 80%, about 80% or so of what influences our health has nothing to do with what happens in a clinical setting. It has nothing to do with what happens in a hospital. It has everything to do with what happens once you leave, the 20 minutes after your appointment, or not 20 minutes, but after your maybe 20-minute appointment, rather. That's what matters with respect to health: where you live, where you play, where you work, where you worship, where you age. And when you're talking about issues like unemployment, you're talking about issues related to violence and especially in the house. All of these things existed way before COVID, but they're certainly exacerbated by the impact of the virus, right? And Wintta, you were talking about earlier access for persons who are medically underserved. All of that has relations to transportation, to these things that happen outside of the clinical setting, and they're what we call upstream considerations, right? So I want to talk a little bit about, I do want to pivot and talk about some of those points. What does it mean when the socially determinant factors of our lives make us ill or make us better, right? Contribute to our wellness, or they make us sick. Right. So before I want to talk to you more specifically about policy considerations that address social determinants. But before I do, I want to bring in the audience and ask you all about social determinant factors around social distancing. Do you feel in your situation that it should be stricter? That social distancing is okay right now? Is it okay to relax guidelines? Especially given what we just talked about in terms of social determinants of health. So you can go ahead and answer that, and let's see what everyone says.
I'm really digging the live poll. That's cool.
It's pretty good, right?
I have not seen that yet on.
Me neither. I'm with you. I'm like, wow, that's awesome.
Yeah, it'll probably pop up in a couple of seconds. But before, as we wait for it, so we queue that up with, for a lot of people, it's not easy to social distance, right? So getting back to social determinants of health, if you live in a household with multiple generations, multi-generational household, especially here we're thinking about our Asian community members, our Latinx community members, those who are coming over and who are very much used to living amongst parents, grandparents, aunts, uncles, that sort of thing. Social distancing may not be something that they can do. Okay, so let's see what the audience says. So most people think that that right now social distancing is okay in terms of guidelines, but not, but still a bit more than a third are saying it should be more strict. Well, time will tell. I think we'll see what will happen. I know that Mayor Bowser has convened her Reopen DC committee. Mm-hmm. We'll see what'll happen there, but we have states like Georgia that have reopened, and at the same time they're still seeing surges in cases, in positive cases. But anyway, I digress. So let's get back to the social determinants of health question. There are a number of policies that have been introduced in Congress well over a decade. One I'm thinking about is the Health Equity Accountability Act, which the Tri-Caucus has put forward for every Congress for, as I mentioned, at least a decade. And HEA for short, this Congress has been introduced by the Congressional Hispanic Caucus under Representative Chuy Garcia. We've seen a number of other related policies or policies related to social determinants of health. I know that Sherry Bustos came out with a bill last year, the Social Determinants Accelerant Act, and then just recently, Representative Barragan just came out with the Improving Social Determinants of Health Act of 2020. I'm wondering, what are your thoughts on what policy will look like moving forward? Do you feel like our policies will be more encapsulating of these non-clinical yet highly significant considerations of health?
Well, that's a good question. I would go back to, so kind of before I get into the question, one of the things that just this idea of just talking about social determinants I thought the comments that Ms. Bass has made, I believe publicly, have been, those have been, in my view, the most helpful comments on the idea of social determinants of health, because as you may recall, after all of the data came out about, 70% of the people in Louisiana who have died from coronavirus have been African American, 73% in the city of Chicago have been African American. And so for anywhere Black people live, they are making up 3/4 of the people who are dying from this, basically. I saw a stat yesterday or 2 days ago that like 180 something people have died from coronavirus in DC, and like 140 of those people are Black, which is very scary, right? It's scary when I'm walking around and I'm like, okay, I have on a mask. Can you put a mask on, please? Because I'm not getting a ventilator, apparently, if I have to go to the hospital. So one of the things that Ms. Bass said, though, early on when that data came out, the initial pushback was, well, Black people, even Dr. Fauci said this, African Americans tend to have, higher rates of, diabetes, hypertension, pre-existing conditions, right? And we'll get to that after coronavirus is resolved. To which, the first thing I think is, so are we just going to we're not going to try to mitigate any of this loss of life until then? That's an unacceptable answer. Ms. Bass, I think in responding to some of the responses to the data, said, I reject that these are things that African Americans have a monopoly on, and that we're just going to be okay. We're just going to be okay letting this play out. I think that people are moved by the data, but I think what folks have to understand is, unlike a number of other viruses, or other kind of illnesses that have taken up public discussion, if Mr. Clyburn said, if one person is sick with coronavirus, everybody's sick with it. This is an airborne, this is something that is transmitted through the air. So to take the cavalier attitude of we'll get to that later means that it's going to be an ongoing problem, because that's who's stocking your grocery shelves. That's who's driving the metro. That is who is interacting with you at work. And so, if we kind of have that attitude, I just think that I've seen people kind of express concern when the data initially was released. What I think I've observed is maybe people being a little desensitized to it. And I think that that's really dangerous, because even if you don't care about outcomes of groups that you don't necessarily fall into, you should care, because it's not eradicated. If people can still get it, it's not eradicated. So I know that, I work in House Democratic leadership. I know that we have been talking about it, but House Democrats only control 1/2 of 1/3 of the federal of the executive of the federal government, and so we're going to need to have some buy-in from other folks in order to get something accomplished on that front.
Well said. Robert, any thoughts or additions?
Yeah, it's just such a, like Corona is a symptom of the bigger problems that we have in society. And like I mentioned before, the stat of 1 out of every 2 adults in America has, a chronic disease it's incredible. Look to the left, look to the right. One of you guys has a chronic illness in America. And a lot of the times that's unfortunately a minority. And this goes back into what's happening in inner cities. It goes back into what's happening in, dense urban areas, even in rural populations. It affects everybody across the board. But, some of these areas, even within big rural areas, are just forgotten. You can't have good healthcare if you don't have, access to a great supermarket, with fresh food, because the default's always going to be the junk food. And that leads to things like obesity and diabetes and chronic conditions, and then on the flip side of that is, how are we going to take care of these folks if we're not reaching them, except when it's episodic, when they get really sick and they end up, in a, hospital or a healthcare facility, and then they end up costing the system tens of thousands of dollars over the course of a couple of days. It's never made any sense to me, which is why I've made, my latter part of my life's career working in what we call digital health. If there's a way that we can leverage what they have around them to be able to, connect them with a device or with, an application where there can be some kind of interaction, and that information goes back to a healthcare provider or a facility that can help trend and track this person's, medical situation, we know way in advance whether or not they're going to suffer, some kind of a medical situation, as opposed to, hey, I'm going to wait until this person is nearly dropping dead and then take care of them. And by then it's too late. Then we've got, months or weeks, to live. And that's the wrong focus of healthcare. It's been the wrong focus, which is why, the public health emergency was invoked, then, the Stafford Act was invoked. Those two things allowed for all the secretarial waivers. The waivers are a big deal. 66 waivers within 2 or 3 weeks were invoked, many of them on loosening the restrictions on telehealth, which includes, using a person's home as the originating site of care. Those are big deals. But, and this goes to one of the questions that I believe was asked in the chat box, all of that disappears the second that, they let the public health emergency either lapse or don't reauthorize it, or Trump decides to, he decides that his determination is that we don't have to have a public health emergency under Stafford Act, and then it's over. And that's kind of a scary proposition, because that could happen like that. And if that happens, all of these waivers that are used right now to really kind of, modernize healthcare, to virtualize healthcare, will go away. And I'm hoping that, Congress and just stakeholders, including those in medical societies and those in hospitals and frontline workers, comment on this. They contact CMS and let them know, this is actually a beneficial way of approaching care, trying to virtualize a lot of the things that before it's required that you have to go to the healthcare facility in order to be able to, meet the requirements and then be able to get paid, especially for older Americans under, Medicare. So anyway.
I want to make sure that you all really take in what Robert just offered with respect to the loosening of restrictions around telehealth, provisions for coverage and coverage parity, as well as pay parity. These are, and also the types of telehealth platforms that can be used. Like, there are a number of states that have, to your point, in terms of loosening and expanding, a number of states have said, well, if you need to, you can talk to your provider over Facebook Messenger. You can message your provider over Skype. Like, these are really very innovative, forward-thinking platforms, but they are under emergency restrictions. So yeah, I completely agree with you. If once the emergency is called off, all of a sudden there's a pullback in these investments and saying, okay, well, that's okay. Then you're right. We're right back at square one, and we'll see continuous exacerbation of existing inequities in terms of health outcomes. I also want to comment before we pivot to another question that we really can't afford to, Wintta, to your point, to wait until after all of this to address disparities or inequities in terms of chronic conditions, especially as they impact marginalized and minoritized communities, especially racial marginalized and minoritized communities. Our nation is changing such that within 10 years or so, and Dr. Puckrin at NMQF uses this terminology, the new majority of people who live in this nation will not be people who are white. It will be people of color. And so when we're talking about what our system has to do to prepare for the diversity of care needs for people who don't all speak English, for people who aren't all of a particular faith, for persons whose original country is not the U.S., and for children who are growing up and they have a very different ideation of who they are in terms of their racial identity, in terms of their ethnic identity. All of that is going to completely just make the system a lot more complex if we don't handle it. So we have to be ready and willing to identify first and foremost, and be okay with saying there are differences with respect to race, and these differences are avoidable. They're not naturally born. They're not biologically based. This is really rooted in long-term structures of power, of resource distribution, and they're driven by policies. In the same way that they're driven by policies, changes can be driven by policies, and we have to make sure that what we're putting in place now has staying power, and that we are really being a lot more forward thinking in terms of where we need to go. But I'm going to get off my soapbox with respect to that and go to another poll. And just talk about what's happening next. So we've focused predominantly on the health related issues, on the social determinant factors. Let's talk about economics. How should the country go about reopening the economy? Should the federal government reopen based on the national curve, or should states open based on its own curve, like Georgia and such like that? Or should states only reopen counties rather, or other smaller regions of the state based on the regional curve? What do you think? That's a hard one. All right, it'll take a couple moments or so for the answers to come back in, but let's go ahead. I want to close with just asking you both, how has your world been impacted by all of this? Where's your head at? Where's your heart at? All of that. And then if the poll comes back up, we'll acknowledge that, and then we'll go on.
It's really scary. My mom is a healthcare worker who has asthma, and when she's had to continue going to work, even though I've told her to quit or get fired. I'm like, might want to just get fired, Mom. But she's a healthcare, and originally they were sending her to a COVID floor, and this is a woman over 60 who is asthmatic. Or telling her she couldn't wear her face mask originally, to which, she reminded them that her child was an attorney that worked in Congress and they needed to correct course on that. It's really scary. It's scary because, you really don't know, as just a public consumer of information, you don't know where to get reliable information from. And the problem that I have is the problem that others have. And so I think that it has shown, I think it has brought a lot of things to light. A number of things that we've talked about on this call and other things, but I think it's brought a number of things to light, and has made me very concerned about my own health and the health of the people that I love. Because this isn't something that you can stay away from a particular food and you'll be fine, or stay away from a particular setting and you'll be fine. This is something that's everywhere, and it's literally shut the world down, and that's unprecedented. And in moments where maybe you think this isn't a small thing, you are reminded that these sports leagues and these sports leagues are billion-dollar institutions, and these universities are have a specific structure that they follow. And if all of these organizations are willing to forego all of this income, potentially put themselves in the way of litigation, in any of those moments that you're just like, oh, I just want to go outside, you're just reminded that, no, this is something really serious, and you could be putting yourself or somebody else in harm's way in a moment of, like, kind of a fleeting moment of selfishness.
Really well said. Oh, I will pause.
Robert, we want to hear what you have to say. Let's see. So most people think that states should reopen in chunks, in smaller chunks, is what it looks like. But then there's also an entire half of you a quarter of you who say, no, the federal government should do it, or states should have their own autonomy. But most people are leaning toward the state options of reopening. That's curious. Thank you.
Context is my favorite word in the English language, because I don't think that people really understand the context under which, hospitals are operating on or families are dealing with, unless you really are personally touched by COVID. And that's unfortunate, because it shows the deep fissures that we have in this country, ideologically, et cetera, and all of that stuff just gets in the way. The reality is that this is, it's a domestic problem, but it's a global problem. The day that the first COVID case was reported in Ecuador, I left that morning with my family. We were there to visit my family, who lives in Ecuador, and my aunt and uncle, who typically live in New York City, are still stuck there because they live on the coast, and in the inner city, it is an epicenter for all of Latin America. They're putting bodies out in the middle of the street. It's been reported on heavily in the New York Times. I talked to my family who actually lives in that city, so I know that it's real, and it is ugly, and it's scary. And talk about a country that does not have access to things like ventilators, and et cetera. So I think what Wintta was saying is so dead on. This is a life-changing event. Imagine in the US, where typically we see other cultures walking around with masks on, that's now going to be the everyday norm. The plexiglass, divider in between tables and in between you and the host in restaurants, that's going to be the new norm. The academic issue, boy, you've got this incoming class next year, which is uncertain as to whether or not they're actually even going to be going to college. And if they don't go to college, they're going to want their money back. I think that Wintta is right on the money. You're going to see academic institutions go bankrupt. This is a huge, huge, profound change. And I'm not trying to minimize what COVID is by saying what I'm about to say. Imagine if COVID was an automatic death sentence like you see in the movies, in a movie like Pandemic. So this is a wake-up call in a way. It's an ugly wake-up call because we still are seeing, 4 or 5, even up to 11% mortality, depending on country by country. But it is a wake-up call that, resources, emergency preparedness cannot be taken lightly, and it has been taken lightly. After SARS, there were reports done as to what we should do in this country, and of course, they went away, given whatever the administration was at the time, and that's unfortunate. And I think that this is a big deal, and it's a big change, and it's going to cause people to change everything, at least in the short term, but it's going to have longer term effects, and it's a global issue. My heart goes out to anybody and everybody that's affected personally by this. We have not been. I'm sheltering in place with my family, except for my family, extended family in Ecuador. But, I've heard of friends that have had to deal with this, and it's harming them economically and socially and everything else. So.
Yeah, I really appreciate the both of you giving us some personal tidbits there. And just to close with some personal tidbits as well, Wintta, my mom is also on the front line. And I was livid when she initially told me that she would be caring for COVID-19 patients. But fortunately, they did eventually move her to more of a managerial role. But now she is back out on the front line, but she's in a testing tent. So she's just she's testing patients, and we're out of Philly, so there are certainly newer cases there. Robert, you mentioned your favorite word is context in the English language. Mine is onomatopoeia. It's sound words, right? Which I find myself resorting to more and more right now when I'm thinking about all that's going on in the world. It's more like or all these sound words that just kind of that's the only thing I can really just use in a lot of situations to just express what's going on, because we're all still trying to wrap our heads around it, and all of us are very much we're professionals. We're very much linked to this world of policy and public health and such like that. So it's not new to us in that way, but it is certainly scary. And to your point about this being a global situation, my heart definitely goes out to everyone around the world. I lived in Southeast Asia for a number of years, and in South Africa for some time in my 20s. And it's very hard for me not to think about what that world was like, especially when I lived in Southeast Asia. I lived in Indonesia. And right now, Indonesia is the hardest hit Asian nation that's still reeling from all of this. And everyone wore masks. Well, a lot of people wore masks there. And now I'm just thinking back to my time, how I did not wear masks. I covered other ways because it's a Muslim nation, so sometimes I would cover. But anyhow, that's all that to say, we're all in this together. And in our separation, our social our physical distancing, I'm hoping that we're still able to find ways to more meaningfully socially connect. And this webinar is one way to do that. It's certainly one way to share information. And I appreciate all that you all brought for us today. And I hope that we will, continue to stay in touch and across various platforms. And I thank the audience for being present. Thank you for your questions and for your energy and attention. And I will give my goodbyes and hand it back over to Brandon Garrett to close us out.
Nah, thanks for that, everyone. I mean, that was good. We got the policy, but then we got the personal stories, and we know that we all are suffering or dealing with this in some form or fashion. I'm sheltering in place, and if you know me, you know I don't like to be anywhere more than 2 days in a row. So this has been very difficult on me. But thanks a lot. One thing I just wanted to mention, if you have ideas for things that you'd like to hear experts speak on, please feel free to share with myself at bgarrett@nmqf.org or Keiko Purnell. She's the one that special assistant, and she manages these things. So we'd love to hear ideas from you. If there's something that you'd like to see more of from NMQF, we'd really like to know that. But with that, I'd like to wish you guys a happy Friday and enjoy your weekend.
Thank you.